Hi, this is Dr. Mike Cymbor with Nittany Eye Associates in State College, Pennsylvania. I'm also the medical director of the Glaucoma Institute of State College, and I'm pleased to present a case to you today. I like objective functional testing because we know all of the weaknesses associated with visual fields. I use the diabetic retinopathy protocol in all patients with the diabetes, and I use the PHNR protocol to help differentiate retinal and optic nerve disease. We have a 59-year-old female who is referred to the Glaucoma Institute of State College as a glaucoma suspect, and the referring doctor says that she has mild nonproliferative diabetic retinopathy. Her corneal compensated IOP that day was 22 in the right eye and 24.7 in the left, with a reported Tmax of 24 and 26. Her pachymetries are in the thick range at 612 and 613, and cataracts and glaucoma run in her family. She's had type 2 diabetes for 11 years, hypertension for 5 years, and hypercholesterolemia for 6 years. A lot of comorbidities there. She has a family history of diabetes and hypertension, and you can see her systemic medications. So utilizing wide field imaging, we can determine that she has mid-peripheral and peripheral dot and blot hemorrhages, a little worse in the left eye than the right, and we can see in the left eye here is a hemorrhage, and here are a few hemorrhages out here. She also has some AV nicking in this area and some venous beading as well. And this case represents the complexity and overlap between diabetic retinopathy and hypertensive retinopathy. These magnified images probably show the venous beading and AV crossing changes a little more clearly, but when we look closely at the optic nerves, we see no obvious asymmetry here. And when we look at our octopus visual field results, we can see some asymmetry in the mean defect. In the right eye, we have a mean defect of 3.3, and in the left eye, we have a mean defect of 1.7. So looking at my OCT-A report, there are a few things that stand out. The first thing is that looking at the ganglion cell complex report, there's quite a bit of asymmetry between the right eye and the left eye. And there's also quite a bit of asymmetry between the superior area and the inferior area. So the supratemporal area on the nerve fiber layer really gets my attention, both here and here. And when you combine it with the ganglion cell complex, that really has my suspicion raised. I don't see any nerve fiber layer defects in that area on ONFOS, but I do see quite a bit of asymmetry on the �𝐮𝐬 chart. Now, when we dig a little deeper into OCT-A metrics, the OCT-A metrics show on the hemisphere view a difference of 6 in the right eye versus only 3 in the left, so quite a bit of asymmetry between the right and left. And then when we get into the quadrant view, we actually see a difference of 11 here versus just 4 in the left eye. So OCT-A shows quite a bit of difference. And in that supratemporal area, there may be some reduction in blood flow here, so that's definitely has my attention. Here is a blown up view of certain parts of our OCT report, and to reiterate, my suspicion lies in the supratemporal area based on this being flagged and some asymmetry superiorly versus inferiorly in the ganglion cell complex deviation map. I always want to try to correlate structure and function, and to do so, I like looking at the polar analysis on my octopus visual field. So the polar analysis converts the visual field into kind of an OCT representation. And so what I would expect to see if there was good correlation between structure and function, long lines like we see here, I would expect to see it in the same area that we see it on the optic nerve where structurally things are being flagged. So what this indicates is within the visual field, we are not seeing good structure and function correlation. We know that the foveal avascular zone can be affected in diabetic retinopathy, and as the diabetic retinopathy worsens, the FAZ, the foveal avascular zone, gets larger. But there's some compelling work, early work, that also looks at foveal avascular zone in relation to glaucoma, and I will point you to Weinreb's group that has some emerging research that shows that foveal avascular zone can be affected both in glaucoma but also in glaucoma treatment. And so foveal avascular zone is something I look at a lot. And looking at the foveal avascular zone in this case, all three metrics show a larger foveal avascular zone in the right eye than the left. A careful angle inspection is also important in all cases of glaucoma and glaucoma suspects. And so in this case, I was able to see scleral spur on gonioscopy, and looking at the angle using OCT limbus to limbus imaging shows that the angles are open but somewhat narrow. We can see the lens pushing forward, pushing the whole iris forward, because of the lens vault that's occurring. So some narrowing, but not much. Remember that there was some visual field asymmetry affecting the right eye more than the left eye, but there really wasn't enough data there to convince me that this patient had glaucoma. And so I ordered an ERG to really explore whether the functional deficit existed and whether it could be localized to the photoreceptor layer, the inner retinal layer, or the ganglion cell layer. And so we can see here, this is the A wave, implicit time and amplitude, B wave, implicit time, amplitude. These are the right eye, these are the left eye. And we want the implicit time to be fast. We want it to be as close to 0 as possible, and we want the amplitude to be strong. We want it to be as close to 100% as possible. So the A wave amplitude here is reduced to 10%, very weak, and the left eye A wave is reduced to 17%. That's also weak. This is most likely due to photoreceptor disruption, probably due to a combination of reduced perfusion from both diabetic retinopathy and hypertensive retinopathy. So the B wave is relatively unaffected, but now we move to our PHNR. The PHNR is a measure of ganglion cell and optic nerve function, and we can see asymmetry both in the implicit time. Remember, we want this to be as close to 0 as possible. So we have 100% in the right eye versus 47% in the left, quite a bit of asymmetry there. And in the amplitude, we have a really weak result, 5% in the right eye versus 33%. So we can see quite a bit of asymmetry in the PHNR, indicating that the right eye is affected, is reduced more so than the left. So now we're going to try to put this all together. We are going to make the diagnosis of hypertensive retinopathy. This is a new diagnosis for her based on her reduced AV ratio. We're also going to downgrade her from mild nonproliferative to moderate nonproliferative based not only on her microaneurysms but on the venous beading that we see. And we were suspecting glaucoma based on structural testing, and also the visual field did show some asymmetry in the mean defect, but when we really tried to correlate structure function using the polar analysis tool, there really was not good structure function correlation. So I wanted to get another test, another objective test, and that's really where the ERG came in. And so we saw a reduction in the A wave that I showed before, but the PHNR, which is a measure of ganglion cell function, really showed a large asymmetry between the right and left eye. And that really is kind of what clinched the diagnosis here. And so we made the diagnosis of primary open angle glaucoma in the right eye, kept it as ocular hypertension in the left, and we sent her for bilateral SLT, and that's kind of where we stand. We are waiting for this patient to have SLT as of today. So a few closing thoughts. I probably would have observed for a little while longer in this patient. I also think it's worth considering, maybe running a 10-2. That may have been that extra bit of evidence that we needed to pull the trigger. And so I think the value of of the ERG in this case, the value of objective functional testing really kind of hits home, where we were kind of suspecting early glaucoma, but having that amount of asymmetry in the PHNR, I think really clinched the diagnosis for us. And that allowed us to jump in and, making that early diagnosis leads to early treatment and really better long-term patient outcomes. So I hope you enjoyed this case on how objective functional testing can be a benefit to my patient and to your patients as well.